Hi, everybody. This is first of a series of screencasts that I'm gonna do from home. Here I'm gonna talk a bit about chronic pain and about how chronic pain relates to various psychological problems. And as we talked a bit before during our second class, I believe uh, chronic pain is a very specific condition that seems to have no well, there are some links with with acute pain syndromes, but it seems that what you need to realize is that chronic pain can in fact be thought of as a specific disease that has nothing to do with acute pain. Okay, so first thing that we need to talk about is the idea of psychogenic pain, and this was fortunately was a popular idea, I would say, in the 70s, 80s, maybe 90s even. But right now, more people are pointing to some obvious problems with that idea, and you need to be aware that this idea is very problematic. So, the idea is that because often pain is present in the patient without any obvious pathologies, uh, that leads to various psychogenic explanations of pain. So what does psychogenic means? It means that if there is no apparent reason for the patient to be in pain, like a physiological reason, like for example, if you have back pain, it can be caused by disc herniation, or it can be caused by a tumor, or it can be caused by some muscle strain problems. But if there are no obvious problems of that sort, and the patient still reports that he or she is in pain, then what is the reason? The reason is psychogenic. What does that mean? That means that the reason is somewhere in the patient's psychological makeup. Okay. Um, if you are being very nasty about it, you might even say that the patient has some sort of a psychiatric problem. Okay. And I knew a couple of physicians that kind of said that this is the case. All right. So there's no obvious trauma, there's no obvious injury, there's no obvious pathology that can be diagnosed either using CTs or MRIs or something like that. So why the pain? Well, because the patient is crazy, right? And so this is what you need to know, that this idea of psychogenic pain goes a long way, and there are still physicians that kind of think this way. Um, and what's also important to consider is that when it comes to pain, when it comes to chronic pain, different therapies often produce similar effects. And great example of this is fibromyalgia, where there are about 50 different pharmacological therapies for that disease. And if you're interested in that, you can read various different stuff online about fibromyalgia and how to treat it, and from opioids and non-steroidal anti-inflammatory drugs to growth hormone injections. So it's not 50 different pain medications. These are actually 50 different pharmacological therapies, hormonal and and others as well. And there are about 50 non-pharmacological therapies that have nothing to do with with pain. Balneotherapy is one great example of that. Balneotherapy is treatment using waters and muds and stuff like that, the things that you do, and you know. Um, I don't know what's the word in English, but there are places that specialize in balneotherapy, like in mountain resorts. Places where they have specialized mineral waters and stuff like that. And These have been proven effective in clinical trials when it comes to reducing pain. Okay, so why is that? What's the reason? Is it a problem? Where's the problem? Because there obviously is a problem if you have about 100 different methods of therapy that are all effective in one given condition. So I would say that the problem is a problem with chronic pain, in fact, and with the realization that chronic pain has nothing to do with well, maybe not nothing, right? But has is not the same as the as nociception, as we talked about before. If you are in a state of chronic pain, it means that, in all honesty, uh, something bad is going on with your central nervous system. I would say that there is a widespread agreement right now in neuroscience that that is the case. Okay, so if that is the case, any type of therapy that has to something to do with the workings of your central nervous system may be potentially effective, and that's one of the reasons why more and more people say that it's appropriate to consider psychotherapy in patients with chronic pain. Okay, but that historically kind of contributed to the idea of psychogenic pain. All right, if you have different therapies that work, then maybe it's about the psychological makeup of a person. And one idea that has to do with psychogenic pain that was very influential back in the day is the idea of a pain-prone personality. Okay, and we're going to talk a bit about pain-prone personalities, and then we'll move to various approaches used in the insurance business, and these can be termed motivational approaches. And then we're going to cover some learning behavioral approaches as well. And then we'll move to probably most mature psychological model of chronic pain, which is the fear avoidance model. So that's the plan for today. Okay, so first of all, pain prone personality. The idea of a pain prone personality is just the idea that some people have specific personality traits that predispose them to feeling more pain in general. Okay? These are people that are more inclined to suffering from chronic pain. Why? Because of the way their personalities are kind of made up. And these two researchers, Bloomer and Halborn, they are kind of famous for publishing a paper that tried to summarize those traits, supposed traits, I would say. And these were, according to those authors, denial of interpersonal and emotional problems, lack of activity, depressive mood, sense of guilt, lack of initiative, and depression, alcohol dependency, and chronic pain in family. And this is funny for a couple of reasons. First reason is that if you kind of imagine that you have all those traits at once, it's kind of obvious that you will feel chronic pain, right? Because if you are at the same time having interpersonal emotional problems, you lack activity, you're in a depressive mood, you have a sense of guilt, lack of initiative, and your family is depressive, alcoholic, or in chronic pain, then you're sure to develop a chronic pain syndrome as well. Okay, so but that doesn't mean that that's the reason behind it. Okay. Second funny thing for me is that, depression, alcohol dependency, and chronic pain in family are thought of as personality traits here. This is completely stupid, at least to my mind. um, and then the probably the most serious problem of this is the problem with with the order, or I would say the reasoning that's behind it. Okay. And of course the empirical support, which is just only one study, but that study is very, very popular. The problem is that there is simply no way of establishing a causal relationship that says that if you are in a depressive mood, or if you have a sense of guilt, or if you lack initiative, uh, that makes you more inclined to chronic pain. Okay. Uh, you know, Another explanation for this, and that's a perfectly fine explanation as well, is that because you have chronic pain, okay, because you are feeling chronic pain, you suffer from chronic pain, you get all those things. So these are not part of your personality or your psychological makeup. These are, in fact, results of having a chronic pain syndrome. And we see that in a lot of people with chronic pain. You see depression, you see a sense of guilt, you see an overall decline in activity, and so on and so forth. So, the causality here is very, very problematic, I would say. Problematic in a way that, this study does not show causality at all. It just shows you some correlational results, right? So if you have chronic pain, you are more likely to have a depressive mood, for example. Of course, yeah, but that doesn't mean that uh, the this personality trait of sort is the reason behind chronic pain. It might be the other way around. Okay. And At the end of this video, I'm gonna address this problem with depression and chronic pain again when we talk about fear avoidance model. Okay, so just keep that in mind. And the logical basis of this theory has been widely criticized. People have said that, different researchers kind of pointed out that this might be also a the entire reasoning behind pain prone personality might be kind of circular in nature, and that's not a good thing for a scientific theory. Okay, if you want to if you have like circular reasonings inside a theory, that's a bad thing for your theory. Okay. And What you also need to kind of remember is that when we're diagnosing various psychological problems, like for example depressive states or anxiety states, or if you want to look into the amounts of activity in people or initiative in people, you generally do psychological questionnaires. And the problem with those and chronic pain is that a lot of those questionnaires are built in a way that they have a lot of somatic questions in them. What does it mean, somatic questions? It means questions that refer to various concrete somatic ailments. And a prime example of that is one of the most popular methods for diagnosing depressive symptoms. That's called the Beck Depression Inventory. And in that Beck Depression Inventory, you have a question. You have an item that says, I am worried about physical problems like aches, pains, upset stomach, or constipation. And I know that it has to do with worrying about them. But if you think about it, if you have chronic pain, you suffer from aches, pains, and so on, right? So having a chronic pain condition makes you score higher in Beck Depression Inventory, pretty much. All right. So that's one of the obvious like methodological considerations, is that if you want to diagnose a depressive state in a person who has a chronic pain syndrome, you need to remember that the tools you use for diagnosing depression might all kind of be biased towards people with chronic pain, because that's the way the questionnaires are kind of formed. And right now, a lot of psychologists are acknowledging this, but you need there. I would say that this problem is known for people who know something about chronic pain, but I'm not sure if everybody who's working with patients with depression is aware of that potential problem. Okay, you need to be aware of that. And another thing is, in a lot of studies on pain-prone personality, MMPI was used. And if you're familiar with psychiatric questionnaires, MMPI is one of the leading questionnaires for diagnosing psychiatric disorders. And the problem with that questionnaire is that it was devised for psychiatric patients. So using MMPI in patients with chronic pain and without any psychiatric disturbances is pretty much inappropriate from a psychometric point of view. And you should not do that. But people do it nonetheless. And the results they get are, I would say that they're obviously biased because it's an inappropriate method. Yeah, and MMPI is also famous for including these types of somatic items. All right. So another approach to chronic pain is an approach that's favored by insurance companies, and this approach uh, says that if no obvious pathology is diagnosed by a physician, it means that the patient either exaggerates the symptoms or malingers. Uh, so symptom exaggeration is that we think that, okay, it's probable for the patient to feel pain, but there's no way that the patient should score 10 out of 10, and on the NRS scale it's just impossible given the amount of pathology that's present in a patient. And as we talked about before, the problem is that pain is subjective, so there's no way of telling how intense the pain is in a patient. Okay, and the amount of tissue damage or the amount of nociception may have nothing to do with the amount of the pain that the patient suffers, and you need to remember that. But it's not that obvious with insurance companies, which have a particular interest in not with providing less money for these people. Okay. uh, and another prime example is malingering and various accusations of malingering in patients who say that they're in pain while there's no obvious pathology. Okay, and because of the new IASP taxonomy, and because of the progress in science in pain research, More and more people are aware of that problem, and there is less in the 21st century. There is less problems with insurance companies refusing to pay money to the patients because of supposed malingering. But that was pretty popular. That's what happened in the 70s and in the 80s in the United States. Okay, so you need to remember about that. And of course, as I said before, no method to objectively test for pain. That's one problem. And methods based on inconsequence are biased. We did not talk about this before, but there are some methods of evaluating pain that use the idea of being consequent in your judgments. Okay, so if a person scores like 7 on the NRS scale, and then after a couple of seconds scores 4 on the NRS scale, you might think that, oh, that's inconsequent. That's a sign of inconsequence. So the person is probably malingering. Well, there's no way of telling whether the person malingers or not, because the pain is subjective, okay, and it may be subject to various fluctuations. So the problem is that there's no way of knowing. But what's also interesting is that there's no empirical evidence whatsoever for analgesic properties of receiving insurance money. So if people receive insurance money, that statistically doesn't make them feel less pain. Okay, so it seems that the problem of malingering is not that widespread as insurance companies would like to think. All right, moving on to more, I would say, appropriate psychological models of chronic pain. The most basic of them have to do with processes of habituation and sensitization. So people can either habituate to different stimuli or sensitize. And when you habituate, thinking about pain, right? If you habituate to pain, you just feel less pain from the same stimulus over time, over prolonged exposure to that stimulus. And if you sensitize, then you feel more pain. Okay, and in general, most people, if they're healthy and they have no other conditions, they are able to habituate to uh, pain of average intensity in appropriate conditions over small periods of time. And that's perfectly understandable, and people do this, okay? Um, but it seems that in chronic pain patients, this ability is distorted, and a lot of chronic pain patients suffer from sensitization. So the same stimuli produce more pain over time. Okay, and that's a problem, and we're not sure why is that, but it may be some sort of I would say a neurological problem even. Okay, in somewhere in the workings of the patient's nervous system. Okay, another idea is the idea of classical conditioning, and you can apply classical conditioning to pain as well. And just so you know, classical conditioning is often called Pavlovian conditioning. And if you remember Ivan Pavlov, he was this Russian physiologist who studied dogs and studied salivation in dogs, right? And what he observed is that the dogs started to salivate because of either some acoustical stimuli or visual stimuli that had nothing to do with food, but they learned the response, the conditioned response of salivation because of prior experiences, right? So because the food was connected with either a light bulb going on, or some sort of a sound, like a beeping sound that was played to those dogs. They started to salivate because these were connected in time, right? So you can think about suffering acute pain as a type of unconditional stimulus that produces an unconditional response. And this response is pretty much biologically given, okay? And it's, everyone has it. So if you feel pain, you have a very, concrete reaction to it. It has components of a stress reaction, like sympathetic activation, secretion of adrenaline, cortisol, increased muscle tension, and in cognitive terms, anxiety. Okay. And this is pretty much an unconditional response that you cannot control. And this is like a universal response to a lot of different painful stimuli. And the idea with classical conditioning is that you can have neutral stimuli, for example, certain moves or sites or places that are conditioned to acute pain. Okay, so the unconditional stimulus that is acute pain is paired with those neutral stimuli. Okay, and because of this pairing, this produces a conditioned response, which is sympathetic activation, muscle tension, and anxiety. Okay, so one example is that people often associate, for example, different types of movement with pain. Okay, and on the basis of classical conditioning, if this goes on for a long period of time, that you feel pain while doing certain movements, then after a while, when the pain goes away, you might learn a conditioned response of sympathetic activation, muscle tension, and anxiety just because of the movement alone without the pain. Okay? In the same way that Pavlovian dogs salivate without the sight of sound, the sight of food, right? Because some sort of a sound went off or something like that. Okay, so this is Pavlovian conditioning of pain. All right, so that's like a diagram for this. All right, so this is the unconditioned stimulus, which produces the unconditioned response. Okay, so pain basically produces sympathetic activation, fear, anxiety, muscle tension. And if you learn that various external stimuli, different places, different things, different sights, different sounds, different movements, and so on and so forth, are associated with pain, these might also produce a response that's termed the conditioned response, which is the same as for pain. Okay, and what's also worth mentioning is that if you think about sympathetic activation paired with fear and anxiety, paired with muscle tension, that if you have sufficient muscle tension over sufficient time, this may also cause pain in itself. Okay, so that's the beginning of a potential vicious circle of pain. Okay, so the idea is that even without obvious nociception, because of classical conditioning, you might suffer. You might have a sympathetic activation, fear, anxiety, muscle tension because of non-painful stimuli, and that as a result may produce pain. Okay, so that's one idea, and building on that idea is the fear avoidance model. And the fear avoidance model is one of the most popular psychological or cognitive models of chronic pain that are around right now. And this is also a model for therapy. So just very quickly, you should be aware that this thing exists. Okay, So the idea here is that you learn. The problem of chronic pain is not only about classical conditioning, but it's also about other cognitive processes. Okay, so it's also about conscious learning, and it has to do with instrumental conditioning as well. And I won't get into that because we don't have time for that. But like the basic idea is that your expectations and your beliefs about pain can influence your behavior. Okay, because they obviously influence our behavior, right? What you think about your pain will influence how you act because of pain. And one example of this is people with low back pain that are afraid that they have bone cancer. Because if you have a acute episode of low back pain, it might, in very small percentage of cases, be indicative of a bone cancer. Okay, and what patients do is that they start to feel pain and they go to, to various, they go to Google, right, and they Google this, and they look at various different causes of pain in the back. All right, and one of those causes, they read about those potential reasons why they are in pain, and they read that, oh, they can have bone cancer. And what happens then? Of course, they are fearful and they're anxious, right? Because they can have bone cancer, right? And that may influence their behavior in various different ways. Okay, from seeking help to not seeking help, because we know that people who are afraid of the cancer diagnosis often refrain from seeking medical treatment or seeking diagnosis. And it's completely illogical, but people do that. People are scared of, of hearing the diagnosis. And yeah, so a lot of different things might occur, and these things have to do with what do you expect the reason for your pain is, and what do you believe that the reason for your pain is, and whether you believe that the pain will go away after a while or not, and so on and so forth. And the main thing about this fear avoidance model is the concept of avoidance. So the idea is that people avoid certain behaviors that are associated with pain in a kind of a similar manner to the one discussed before with classical conditioning, but the reasons for that are kind of more complicated. But nonetheless, what avoidance produces is avoidance is a bad thing here. Why? Because avoidance may lead to intensification of pain, stress, and depression. Okay, and why is that? I'm just gonna show you this picture because that's a good picture to understand the whole idea. Okay, so it all starts with some sort of an injury. Okay, it can either be traumatic or it can be a disease or whatever, right? But some reason behind the first nociception, I would say. Okay, so you're in pain. Okay, you suffer from acute pain. All right, and now the idea is that you can have this pain experience in a lot of different ways. Okay, and the fear avoidance model kind of assumes that what's crucial here is whether you respond with low or no fear and anxiety about your pain, or you respond with what's called catastrophizing. Okay, and catastrophizing is, I don't know if you're familiar with psychiatry yet, but catastrophizing is a term, it's a bit of a psychiatric term. So what catastrophizing means is that if you have a person that's catastrophizing, that person is prone to interpret various different things that are happening in that person's life in terms of catastrophe. So everything that's happening is pretty much bad and negative. Okay, and what's also characteristic is that there are a lot of thoughts about the negative side of things, right? So there's a lot of negativity, and these people believe that that something very very bad is gonna happen. Okay, so catastrophizing is like a like a very specific sort of fear or anxiety, I would say, that has to do with seeing only the negative sides of a given event. All right, and if you catastrophize in terms of pain, that simply means that you interpret your pain as a sign of catastrophe. So, getting back to the example with bone cancer, if you think that you are in pain because you have cancer and you're gonna die, that's catastrophizing. Okay. Of course, some people actually have cancer and they eventually actually have a high chance of dying, right? But in those people, in those patients, it's kind of appropriate for them to feel this way, right? But if you interpret every small kind of every small ailment in this way, that's a sign of a catastrophizing strategy. Okay, and also remember that it has nothing to do with your personality. Well, it has something to do with your personality, but it's not like a biological given. It's not like it's genetic or something. It's not part of your makeup. It's not part of who you are. People might catastrophize, they might be perfectly fine, and then one day after, for example, a stressful life situation, that might start to catastrophize. Okay, so it's not like it's an individual differences kind of thing. It's not that stable over time. Okay, it can happen to, to maybe not to everyone, but to a lot of people in different points in their lives. All right, so it's either catastrophizing or having low or no fear. And if you have low or no fear about your pain, that's good for you because you can confront the new reality and then you recover. But if you start to catastrophize, what happens is a serious, like a cascade of things that form this vicious circle of pain. Okay, of chronic pain. So what happens is that because you catastrophize, you start to be fearful of your movements because you think that movement may produce re-injury. Okay, and we see that with patients with low back pain. For example, these are people who stop moving, and that's why in a lot of cases physicians are asked to encourage their patients to not stop their activity. Okay, to remain active even in spite of pain, because you won't get hurt, but you might stop this vicious circle of fearing to move. Okay, and if you start to be fearful of your movements, uh, what happens is avoidance happens. So you avoid certain activities, you avoid certain behaviors that become associated with pain, and you start to be hyper vigilant about different signs of pain. Okay, so everything that in your to your mind at least you kind of predict that's gonna be painful, you don't do that. Okay. uh and this all these things are, as you can probably imagine, these are not very good for you, and these may lead to disability and depression. Okay, and we know for a fact right now that if you are in a depressive state, this kind of amplifies your pain experience. This is what you need to remember. Okay, this amplifies your pain experience, and because of this amplification, your pain gets worse. You are you tend to catastrophize more. You tend to fear your movements more, and you avoid more, and you have more depression, and then you have more pain, and so on and so forth. And that's the vicious circle that is very hard to stop. Okay, and this produces a chronic pain state that may last for several years, even. Okay, even without any obvious pathology. And that's the fear avoidance model of pain. All right. Okay, thanks a bunch. In the next screencast, we'll talk a bit about low back pain specifically. All right, thanks.